Thank you so much, and it's really a privilege and honor to be able to present at this Congress. And my name is Vaduganathan. I'm a cardiologist at Brigham and Women's Hospital in Boston, Massachusetts, and it's a pleasure to present biomarkers in heart failure. These are my disclosures. As many of you know, heart failure has really rapidly expanded globally. Here are US estimates in which the prevalence of heart failure is projected to rapidly rise over the coming decade, and concordantly, the costs and resource allocation associated with its management is projected to increase. Indeed, prevalence estimates in multiple countries globally have been noted to rapidly increase in recent years related to aging of the global population, as well as advances in medical therapy such that patients are living longer with the heart failure syndrome. Unfortunately, we've also seen increases in hospitalization rates in many global settings. Much of this may be also related to longer durations of heart failure syndromes, as well as increasing complexity of illness such that patients are living with increased comorbidities. Thankfully, now we have a spectrum of available drug and device therapies, as well as advanced therapy options, including transplantation and mechanical circulatory support, to address the global needs of patients with heart failure. When evaluating the global population of patients at risk and patients with established heart failure, there's a large burden of disease, especially in the primary prevention population. This is patients who do not yet have an established diagnosis, but may have at-risk features that may identify them for progression into the heart failure syndrome. So I'm going to speak specifically about this spectrum and how biomarkers may play a role in helping us triage our therapies and triage and allocate our resources accordingly. We've seen a rapid increase in the availability of biomarkers in clinical practice across the spectrum of cardiovascular diseases. Indeed, in the early 1990s, in the red arrow, is when the natriuretic peptides, NT-proBNP and BNP, began to become clinically available and began testing as well as being routinely available in clinical practice. You can see since then we've seen a rapid tide and an increase in biomarkers to date. So I'll focus the majority of my talk around natriuretic peptides. Natriuretic peptides chiefly are synthesized as proBNP. These are subsequently cleaved into an active peptide, that's BNP, and then an inactive fragment, N-terminal proBNP. These are released in 1-to-1 molar ratios and are primarily driven by cardiac hemodynamic stressors, namely volume pressure and volume overload states. Once released, the active form of BNP binds to natriuretic peptide receptors on cell surfaces and produce intracellular pathways, including augmentation of cGMP signaling. These allow for physiological changes such as vasodilation, volume changes, natriuresis, as well as even central effects. So what are the functional differences between N-terminal proBNP and BNP? Because these are the most commonly used peptides in heart failure management. N-terminal proBNP is, as I mentioned, hormonally inactive. It's 76 amino acids. It has a much more stable half-life. It's a longer half-life, 60 to 120 minutes. And it also is stable as a blood sample. It can last up to 3 days at room temperature. In contrast, BNP is hormonally active. It's a shorter fragment, 32 amino acids. It's a shorter half-life, 20 minutes, and is less stable than N-terminal proBNP. I want to also draw attention that there are many commercial assays available for the measurement of natriuretic peptides, and each may have its own standardization and reference ranges, and so they're not entirely interchangeable, so we need to actually use our own reference standards for our own laboratory assays in our local populations. Just a quick mention of some of the other biomarkers that may have utility in heart failure management. Of course, we're quite familiar with cardiac troponins, as we've heard from Professor Rosano about the important context in acute coronary syndromes. And in fact, in the context of heart failure, ischemia may be an important driver for troponin release in the context of a failing myocardium. But in addition, there may be other mechanisms of troponin release from injury states in heart failure, primarily related to myocardial stress in the context of volume excess. And this may lead to both reversible and irreversible changes in myocardial injury. And I'll just note one other biomarker, GDF15. This is a stress biomarker, and it's a stress responsive member of the TGF-beta cytokine superfamily. Its response to a number of signals, include inflammation and remodeling, and while it is released by a number of different organs and different cell types, thus is less specific perhaps than the first two biomarkers, it is released from cardiac myocytes, including related to mechanical stress from pressure overload state. And so may be an important biomarker in heart failure management. So let's focus on the role and expanding role of natriuretic peptides in heart failure. To date now, we've seen a number of uses of natriuretic peptides that have really spanned the spectrum of heart failure management, from initial diagnosis, prognosis, management, therapeutic consideration, even inclusion in clinical trial. Of course, in this short segment, we can't focus on all these elements, but I want to focus on two particular use cases. And first is this pre-heart failure state. That is, patients who are at risk for heart failure, and how can natriuretic peptides actually guide our management? And the second is on the serial use of natriuretic peptides in patients with chronic heart failure. So in patients who are at risk, and this is one such at-risk population of patients with diabetes that we'll focus on, but there are a number of at-risk patient populations, including chronic kidney disease, post-MI myocardial, post-MI LV remodeling, and type 2 diabetes are key contributors to progression to heart failure. Natriuretic peptides and other biomarkers play a central role in identifying patients at highest risk for clinical progression. Here are data that the cutoff of 125 for N-terminal proBNP has very high discriminability in distinguishing who may progress versus who may not progress to ultimately developing clinical outcomes, including death and cardiovascular hospitalization. Furthermore, this very clever study embedded in the ELIXA trial serially measured N-terminal proBNP, including leading up to a hospitalization. And you can see that while in blue, among patients who are on the path to a heart failure event, they have a steady increase in natriuretic peptides. And then in the days prior, in the 6 months prior, you have this sharp increase in natriuretic peptides. In contrast, in black, the black trajectory shows patients who do not have heart failure hospitalizations. And you can see here the trajectory is very stable, that patients who do not experience clinical events do not experience changes in the overall serial levels of N-terminal proBNP levels. So it may stand to reason then that natriuretic peptides may actually guide our intensification of therapies, our management decisions. And indeed, this was tested in a trial called Pontiac 1. And this identified patients with type 2 diabetes who are at high risk. Those are patients who had an elevated natriuretic peptide level of greater than 125. That was greater than that cutoff. And they randomized them to a control group that was standard of care or intensified management with a renin-angiotensin system blocker or and a beta blocker. And you can see here, even in this modest sample of just 300 patients, over the course of 2 years, in red here with this treatment intensified group, you can see that the natriuretic peptide guided approach guided intensification led to fewer hospitalizations and deaths in this at-risk patient population. We now have 2 randomized clinical trials that are larger, that are using more contemporary therapies that are underway, evaluating the same question. Pontiac 2 is a randomized clinical trial of N-terminal proBNP as well in this high-risk population of diabetes. This is being conducted in Austria, Spain, the Netherlands, UK, and New Zealand, and is again testing the strategy of RAS inhibitors or beta blockers in determining if truly events could be reduced with this treatment optimization strategy. Furthermore, there's a trial called ADOPT, led by Professor Carolyn Lam from Singapore. This is a trial that's evaluating a more contemporary set of therapies, including the sodium glucose cotransporter 2 inhibitors. So they're asking the question, could intensified preventive therapy in patients who are identified at high risk with N-terminal proBNP levels that are elevated, could they actually reduce clinical events in follow-up? And in fact, the guidelines now recommend that can be considered to guide decision-making in this early stage of decision, these at-risk patients. And among patients who do have elevated levels should be referred to a cardiovascular specialist for additional risk-lowering management options and monitoring to prevent the occurrence of LV dysfunction or new onset heart failure. And I'll just mention that we've really focused on N-terminal proBNP. There is high value in also using other markers in adjunct. Here in this study, we, in an observational setting, we assessed whether combination use of multiple biomarkers can actually improve our risk stratification of subsequent heart failure events. This is again in this high-risk patient population of type 2 diabetes who is going to progress to heart failure. And so N-terminal proBNP combined with these other biomarkers in a biomarker score, identified patients in stepwise manner to have higher risks of clinical events in follow-up. So patients with multiple abnormal biomarkers indeed have the highest risk for progression to heart failure. So you could think that in a projection then, patients who are at highest risk for heart failure events may actually be at have the greatest risk reduction with therapies targeting heart failure prevention. And so here we estimate with the SGLT2 inhibitors whether use of this biomarker guidance may actually improve the allocation of the SGLT2 inhibitors. You can see in gray and green, those are patients with low or no biomarker abnormalities. And you can see there, they have very low risks of progression. In those patients, they may not need the use of SGLT2 inhibitors. In contrast, patients who are at high risk with multiple abnormal biomarkers are at very high risk of progression. And you can see there that those patients may specifically benefit from risk-lowering therapies. We've also now applied this in a randomized clinical trial. This was the I'm so sorry, it's skipping ahead here. We've also applied this in the Canvas clinical trial program. This was a randomized clinical trial of patients with type 2 diabetes. We assessed a multi-marker score. This is a number of biomarkers, including high-sensitivity troponin. And in fact, the use of this multi-marker approach did indeed identify patients at high risk for progression to heart failure, and found that the use of SGLT2 inhibitors had similar relative but higher absolute benefits in patients who were identified with high biomarker levels. So to close this first section, I'd like to kind of re-emphasize this universal definition of heart failure, in which now, as of 2022, biomarkers have a central role in the definition of how we define what heart failure is. And in fact, natriuretic peptides play a key role in identifying those at risk for progression to heart failure. And that is going to be very important to consider and may allow our future consideration of guidance of how we manage these patients who are at risk for progression. So we're going to shift gears to whether natriuretic peptides may play a role in outpatient monitoring and treatment guidance in people with established heart failure. So this is a central issue that has been addressed with more recent data. People who have established heart failure is critically important in forecasting subsequent heart failure events. For instance, patients who have high levels in both at baseline as well as in follow-up have the highest risk for progression, whereas those patients who have initially high levels but then move on to have low levels then have a lower overall event rate. So we clearly know that changes in biomarkers are important in forecasting prognosis. We also know that many of our therapies lower natriuretic peptide levels. Of course, chiefly decongestion with diuresis lowers natriuretic peptides. But in addition, our foundational therapies, ACE inhibitors, ARBs, beta blockers, MR antagonists, even some of the device-based therapies lower natriuretic peptide levels. Furthermore, some of our newer therapies like sacubitril/valsartan lowers NT-proBNP levels. There was some mixed data about whether it may actually increase BNP, but more recent data suggests that it probably does not substantially increase B-type natriuretic peptide. And SGLT2 inhibitors modestly lower natriuretic peptide. So because of this, it asks the question, could we use therapies to actually guided by natriuretic peptide levels? And this was tested in an earlier trial called GUIDED, in which internal proBNP was used as a guided strategy compared with usual care in about 1,000 patients. And on average, though, as you can see in the Kaplan-Meier curves, there was no difference between this guided approach versus a usual care strategy in subsequent events. And this was related to heart failure hospitalization or cardiovascular death. So why might this be the case? Well, the authors posited that in this clinical trial setting, the number of treatment optimizations, even in the control arm, was quite strong, and so maybe that neutralized some of the results. Certainly, patients may be more advanced in their illness in the guided trial compared with usual care. So many potential scenarios that could explain these results. However, this trial did result in a neutral endpoint. We have many learnings, though, from this trial that I'd like to put forward. First is that we do know that people who achieved low natriuretic peptide levels, namely N-terminal proBNP less than 1,000, clearly do better in follow-up. And so here we have some cross-sectional data on the left where you can see an immediate escalation of clinical events as you move up above a natriuretic peptide level above 1,000. And in fact, when in the guided trial, in patients who have achieved N-terminal proBNPs less than 1,000, those patients had improved left ventricular remodeling in follow-up. So clearly it is an important target for therapy and may correlate well with other improvements in care, such as reverse remodeling. Furthermore, patients who spend more time at N-terminal proBNPs less than 1,000 actually have lower cardiovascular event rates in follow-up. And so, again, suggesting that this may be an important target for how we actually monitor and aim to target our therapies. And furthermore, the serial use of N-terminal proBNP and the prognostic ability extends across the ejection fraction spectrum. We now know that there are therapies available even in mildly reduced and preserved ejection fraction. You can see here, even the prognostic ability may be even stronger in preserved and mildly reduced EF with respect to subsequent outcomes. And here is related to sacubitril valsartan. So how do our therapies actually influence this? You can see here again from the trial paradigm heart failure that patients who achieved a natriuretic peptide less than 1,000 had a markedly lower event rate in follow-up. In fact, sacubitril valsartan was nearly twice as likely as an ACE inhibitor to achieve this low natriuretic peptide level target of 1,000. So that really puts it into perspective about that while the pure guided type strategy was not successful, we do know that patients who achieve these levels of low and natriuretic peptides do better. And so it is a clear target for our patients. And so we should strive in practice to optimize their clinical status, their volume status, medical therapies, and medical therapy options to target levels that are low. So to conclude, this is really the current summary of where we stand, and we have high level of evidence in which natriuretic peptides and biomarkers play a key role in every aspect of heart failure care, from heart failure prevention, that is, we discussed that kind of biomarker-based screening strategy to identify those patients at risk for progression who may benefit from early treatment optimization, as well as referral to cardiovascular specialists. We discussed, we didn't discuss, but natriuretic peptides have a huge role in the initial diagnosis of heart failure, both in chronic and acute heart failure states. Has, of course, a prominent role in prognostication, including at the time of discharge from hospitalization for heart failure, and may guide the subsequent treatment allocation scheme by the serial monitoring of heart failure. And that may be a perspective for the future of where we move towards, in which we use biomarkers to guide our everyday decisions in heart failure. So I thank you very much for your time and attention. I apologize for some of those technical glitches, but I look forward to any questions that you may have.